All right, good afternoon, everyone. Welcome to our first webinar in a series focused on mental health and substance use resources. Today, we are going to discuss, we're going to actually be highlighting two community mental health resources that are located both on the north side of the city and the south side. My name is Elizabeth Gonzalez. I'm the Associate Director of Birth Equity here at EverThrive, Illinois. We are joined today by our partners at Montrose Behavioral Health Hospital and Human Resources Development Institute, known as HRDI, who have done extensive work to create accessible community mental health services. They will provide an overview on their organization's mental health services and impact at the individual and community level, as well as offer considerations for all of us as we work to better serve our communities. So before we get started, here's a little bit more background on EverThrive Illinois. For more than 30 years, EverThrive has been advancing the health and safety of Illinoisans by supporting access to quality care and providing resources to achieve health equity. Our aim is to affirm and center the experiences and voices of communities most impacted by injustice, to achieve reproductive justice for all people and families, especially those in Black, Brown, Indigenous, and LGBTQIA communities. We ensure they have access, resources, and healthcare necessary to create and sustain healthy families on their own terms. And so just here shows our mission, our vision, and our values. Our values are reproductive justice, anti-racism, centering the most impacted, bold action, and transformation. Just some housekeeping rules. Just if you can all just please keep yourself muted to reduce background noise. A follow-up email with materials will be sent to everyone who is registered. Please feel free to type any questions in the chat box as we go. There will be a Q&A period at the end of the presentation. So if we can hold off on questions till the very end, that would be great. And then just our agenda here today, we'll start with some introductions. We'll get into the presentations, do a Q&A session, resource sharing, and then we'll wrap up with an evaluation. So our first speaker today is from Montrose Behavioral Health Hospital. Her name is Kayla McGinnis, and she's a director of business development. I'm actually going to turn it over to her. And Kayla, if you can just let me know when to move on to the next slide as we go through the presentation.
Awesome. Thank you so much, Elizabeth. Hello, everybody. So my name is, like she said, Kayla McGinnis. I'm the Director of Business Development for Montrose Behavioral Health Hospitals in Chicago. Yes, hospitals with an S. We have opened our second hospital, which is fantastic. Just a little bit about me. I've been in the behavioral health space for, I hate to say this, 22 years. I don't feel like I'm that old. But I love this field. I love what I do. My time in Illinois, I spent a lot of it with Gateway Foundation. I was there at the Aurora location as their admissions coordinator for a very long time. I've worked at Rosecrance as well as Symetria. So just a little bit about me. You can go to the next slide. So I believe, so bear with me with my presentation. The one I sent her may or may not include the adult, but we opened about 2 years ago with our children and teen location in Chicago. Just a little bit of background. We are, I'm not hearing a background feedback. Sorry about that. We are an Acadia-owned facility. So Acadia, who is the parent company for Timberline Knowles, who is just a point of reference for the Illinois market. But we're no longer the Chicago Lakeshore Hospital. So we purchased that old facility, rehabbed it, and opened it for children and teens because there was such a great need, especially post-COVID. So at our current location, we have 60 beds in total, 20 beds for children, which is a mixed gender unit, ages 5 to 12. And we say that, for just the purposes of individuals knowing that it is a mixed gender unit. We do have an adolescent female, assigned at birth per DCFS unit, ages 13 to 17, and then 20 more for the adolescent male assigned at birth, ages 13 to 17. With that being said, we do allow patients who identify otherwise, whether, they're part of the LGBTQI plus, maybe they're non-binary, however the patients identify, we try to be as patient/client centered as possible, in as long as we're ensuring safety and well-being of the patient as well as the other patients on the unit. So that means that a born female individual who identifies male can and will be on the 5th floor on that male assigned unit, again, if that's clinically appropriate and necessary. So we, again, want to be we want to affirm their identity in every way, shape, and form, because how does someone get well if they're unable to really express and be their own person while they're with us? Our intensive outpatient just opened about 2 or 3 weeks ago, and that's an IOP for ages 12 to 17. And the intensive outpatient, again, is that 3 hours, 3 to 4 times per week. You can go to the next slide. All right, so we are a primary mental health facility, meaning that anybody that were to be admitted at either our adult or adolescent facilities would have a primary mental health diagnosis: depression, anxiety, ADHD, bipolar, some of the things listed, or who are experiencing any type of psychosis, suicidal ideation, homicidal ideation, thoughts to harm themselves, others, or even self-harming. Sometimes we see that as well. Next slide. And we also, I think in the world that we live in now, co-occurring is no longer abnormal. I think a long, long time ago, patients would come in and they'd want to address one thing. Well, we know that that's really not the case. So when we talk about secondary diagnoses, that can be anything from substance use disorder to maybe an autism spectrum, PTSD, OCD, ADD, I mean, any of the DDs that we all know and love, right? And so even in disordered eating is something that we're able to address as well. When we talk about people's co-occurring, again, comorbid, dual, we have a lot of different things that people utilize throughout the field, but any of those secondary things, for the most part, we can definitely manage those. Some of the things that do get challenging in our level of care, because we are inpatient, we're very acute psychiatric stabilization. If patients are nonverbal or cannot perform their own ADLs, those are a couple things that aren't necessarily exclusionary, but are very challenging. So we do everything case by case. All right, next slide, please. Insurances, that's one of the questions we get a lot. And I always put the Medicaid and the MCOs first, because with commercial insurance, we all know there's a lot more opportunities. So we're really honored that we can support individuals who have Medicaid, and especially the MCOs, because not every hospital takes them. So right now we can take all the MCOs. I just listed a few of them there. And then commercial, we can take all the major commercials as well. And then we do work with patients who are, let's say, unfunded. We get that question quite often, where normally if they're under the age of 18, we work with our local SAS agencies to get them, a temporary RIN quickly. And if, with the adults, we work, a lot of them are, sliding scales, really just, we're looking at maybe some super funding or different things like that. But, we're a psych hospital. So if they walk in, they need to be admitted. We admit them regardless of their ability to pay. But when, people do tend to navigate the system before sending individuals based on who takes what insurance. So just a good overview of that. Next slide, please. And so with our adolescents, so parent/family involvement, for us it is not optional. We do really kind of put pressure on the families, because what we know is that the individuals that we're treating, they have to go somewhere when they leave us, whether that's to residential, a day program, intensive outpatient, things of that nature. So family sessions, most are virtual because that's a little more convenient for the families, especially if they're juggling other children, other family members, other needs, work schedules. However, we do allow in-person, and we try to encourage that, because that in-person dynamic is very different. I think we've all probably experienced that than if they were, again, you can't always get the real emotion or, tell what's going on if they're, via the phone or a device. So visitation is newer to us. We started that in November. So it's really exciting to be able to see the patients and their families interact. It tells a lot about what's going on in that relationship, and how we can maybe navigate some of the barriers to communication, or even just recovery in general. So again, some do a virtual and majority are in person. So you can go to the next slide. And then for our adolescent building, so we do have education on site. So we do 2 hours per unit, and it's all age appropriate based. We use an agency called LearnWell. So they send us a licensed educator who's licensed in the state of Illinois, and then they work with each unit respectively. So if the child is 5 years old, they'll work on maybe kindergarten type things. And if they're 15, then they'll work on things that maybe, if they're a freshman in high school, what does that look like? The caveat here being, if they're not well enough to participate in school, they'll be doing other things like maybe an extended individual session. Maybe they're doing some activity therapy. Maybe they're having an additional one-on-one with our psychiatric team. So there could be a gamut of things that they're doing because we always tell schools, as much as we love them and we really want them to stay engaged at school, if they don't get well while they're with us, the problems at school are likely to continue, right? The barriers to learning are likely to continue if we're not addressing the mental health needs. And I always like to say too, just because they come to us doesn't mean that they're going to be put on, medication. Not everybody's medicated, especially on our mixed gender children's unit. We're not always gonna be like, oh, this 5-year-old needs a slew of medication. Sometimes it's behavior modification. Sometimes it's mild parenting that we can, help set some of those things up. So the parents might be parenting different or just gaining some more skills while they're with us. And as far as discharge planning, we like to make sure that the school, any outside agencies, primary counselors, any of those individuals who will be assisting with ongoing care from an individual when they leave us are always included in our discharge planning. Next slide. Oh, that's it. And then just real quick on our adults, everything is pretty much mirrored. The only big difference with our adult is that our lengths of stay are a bit shorter and we don't have that education component. So we can take 18-year-olds who are in high school. They just won't be doing actual schooling while they're with us, but most of the schools are pretty understanding of that. Insurances are the same. We just have 101 beds versus 60. So between the two buildings, we have 161 beds.
Thank you so much, Kayla. We appreciate it. If there's any questions for Kayla, we'll hold them till the end of the next presentation. I'm actually going to turn it over to Dr. Audrey Tanksley, who's the Chief Medical Officer at Human Resource Development Institute. Dr. Tanksley, just let me know when to move on to the next slide.
Go ahead, move on. Thank you so much for the opportunity to present here, and thank you to everyone who showed up after lunch and is awake for this. So thank you. I'm looking forward to telling you a bit about HRDI, which hopefully is going to be reinforcing what you guys already know about the organization, but please go ahead and move on, Elizabeth. So sorry this didn't come out quite well in this transition, but this is just the mission of HRDI and Friend Health to provide a high quality, patient-centered integrated system of care for all. You can go on to the next slide. This is just going to tell you a little bit about the organization in the sense that, because I'm not going to read all these slides to you guys. I'd like to get to the meat and potatoes so we can have time for questions and such. But basically, both Friend Health and HRDI are organizations that provide healthcare services on the south side of Chicago. HRDI founded in 1974 and then Friend Health in 1998. So both with very long histories, HRDI about twice as long, of providing these services in the community. In about 2017, the organizations merged, and so now HRDI is a fully wholly owned subsidiary of Friend Health, which is why you'll see that we'll kind of talk about them in context, but both provide a very extensive array of services in their respective companies. You can move on to the next slide. This is just showing, that was just showing, they're both accredited in various different ways. Friend Health is, for anyone who's not familiar on the call with the term, FQHC is a federally qualified health center, which means it provides physical health care across the spectrum of pediatrics, maternal or OB and gynecological care and primary care services. And then HRDI is a community mental health center and now a certified community behavioral health center, and so provides the spectrum of behavioral health services across, but we'll go through that later as well. You can go past this. These slides aren't showing up very well on the way that they integrated in this for some reason, Elizabeth, so I'm sorry about that. That other slide was basically just showing you what you couldn't see was that we service pretty much every community on the south side of Chicago. Like, I don't know if there's a way to scroll down on that slide, but originally the slide showed it all. And what it shows, basically it shows that we service all South Side communities, including, there you go. So it's an extensive list because our catchment area actually goes from essentially around, what's considered the near South or South Loop, all the way out to the South suburban area of Cook County. And so we have a very large catchment area, and we try and do what we can, as you see, throughout 30 services and nearly a dozen different sites to provide those services. You can go on to the next one. It's okay that other slide didn't show up. These are just people who work here, and so you can move on to the next slide. And the leadership. These are for our HRDI. I would say this is probably a really, as far as leadership goes, Eugene Humphreys, our executive director. Deb Parnell is a face that I think is important to know, especially as we're talking about linking services throughout other organizations. She has been instrumental with HRDI for a number of years and leads most all of our efforts around CCBHC and those things. So I would say she's an important name to have associated with HRDI. I am probably the newest member of this team. I am the Chief Medical Officer of Integrated Health at both organizations, Friend Health and HRDI. I oversee all of the HRDI organization, as well as the behavioral health aspects of the Friend Health company, and blend those together as well as with the care coordination and such. Dr. Alexander is actually our licensed clinical psychologist. He is heading up our child and adolescent programs at HRDI, and that is an area that also is very extensive in the services that we offer and are actually building along with our CCBHC and expanding. And so I think it's really important for you guys. That's another name that I would say is really important to know. You can move on to the next slide. This again just kind of shows our catchment areas. We service 17 different zip codes across the city. So likely we are probably servicing most of your clients, or at least some of your clients in these areas in some way. We typically try not to cross out of, over our catchment area because there are other, organizations that provide those services, but we are a provider that's dispatched for crisis services through 988 and such. And so there are rare occasions, but times that we do cross these catchment areas. But for the most part, we service 17 zip codes. What does this mean? 7 FQHCs and 5 CMHCs. That means that we have 12 different locations. I thought I might have had them on there for our federally qualified health centers and 5 community mental health centers. Go on to the next one. Let me see. Do I have them listed in there? I thought I did, but okay. This is just kind of demographic information. We service everyone. We have, in the event, I'm going to say this just because I'm not quite sure if that slide came over or not. Our 7 FQHC locations are on 47th and Ashland, 55th and Pulaski. We have 2 locations there. We have a location on 59th and Western, 63rd and Cottage Grove, 51st and Calumet. Yeah, we have a center inside of one of the CPS schools called Beethoven. Yeah, so those would be the FQHC sites, and then our HRDI sites. We have 3 methadone opioid treatment outpatient treatment facilities, and those programs are located on 51st and Calumet. I can make sure you guys get this afterwards as well too, Elizabeth, but 114th in Michigan in the Roseland community, and 80th and Racine in the Auburn Gresham community. So that's where those three are located. We also have two residential supra homes, so substance use recovery homes that do, oh, that's a great question. And then the other, are the questions safe for Anne Elizabeth, or do you want me to answer this now?
It's up to you, doctor. You can answer that question now or save it for the end.
Okay. All right. Well, I'm gonna save it for the end but I definitely want to make sure that I answer that for Mary. So let's go ahead and move on to the next one, because again, I want to make sure we hit all our time. Okay, so what do we offer behavioral health wise? So our community-based mental health services, we have a full range of services, as I mentioned, from child and adolescent through adults. I am grateful to see Kayla was talking about the inpatient hospital services. Everything that we offer is outpatient, various different levels of service, everything from level 0.5, where we do prevention in schools, to level 3.5, where we're doing actual residential and monitoring and care for substance use. Let's see, as we mentioned here, children, we have the programs for the adolescents, for the children, the adolescents, the drug and early intervention. That's our level 0.5 inside of the schools. We have crisis screening and psychiatry. Actually, Dr. Alexander is building an ABA program. So we do testing, starting our 0 to 5-year-olds, autism spectrum disorders, and treatment services from there. And then at our FQHC side, we actually do testing for ADHD. So when young people when there's a concern about trauma versus anxiety or ADHD, we do have a couple PsyDs at the FQHC that do that battery of testing for that as well too. So we have a spectrum of testing that goes across. Our crisis and trauma-informed care is also a continuum of care. We have a community triage center in the Roseland community, far south of Roseland on 115th Street, 24 hours, 365 days a year, where people are able to walk in and to receive assessment and get services on site. We do allow individuals to be there up to 23 hours at this point. It's not a stabilization unit. And so we do help with shelter placement, and we have a harm reduction vending machine on site. We try to do, in the moment crisis counseling and things of that nature to get people to the right interventions. We have a front door diversion program and a first episode psychosis program. And so we're really trying to help people to receive the services they need, absent of law enforcement involvement in that kind of as little as possible. We also do, as you see, all of the things that go along with that, right? So we have a gambling program as well. We do have a home that our residential treatment facility for our women do allow pregnant women. We also allow women with children up to the age of 10 years old. So we can allow, for people, that's typically a barrier for women entering treatment when they don't have childcare. And so we try to eliminate that barrier as much as possible. We also, again, we serve dual diagnosis. Oh, I'm sorry, I'm getting a little bit of feedback. Dual diagnosis. We also do case management. We have a high-risk infant program and family case management services. You can go on to the next slide. So really just an array of services, to be honest with you. As I mentioned before, our primary care is really mostly through our Friend Health location. And it's the full spectrum of primary care that you would find in a FQHC. They also have additional specialty services. So we have a partnership with the University of Chicago where the infectious disease doctors come over and actually have clinic on site and see our patients here. We also have asthma clinic services. We have at least 2 of our locations right now offer dental services and a third location will be offering it soon. We also have the mobile dental van where we are able to pop up in locations and provide dental services, full spectrum lab services, and again, full spectrum OB-GYN. Our women's health program is pretty robust at our 63rd Street location, and our OB-GYNs actually deliver at the University of Chicago. We offer, go ahead and move on to the next slide. Let's kind of see. We have a number of collaborations, probably with some of the organizations on this call, as well as all of the key collaboratives that are looking to transform healthcare in the state. We're a part of those consortiums as well as a part of those working groups. And so, we look forward to being collaborative and as much as we always can. You can move on to the next slide. These are services that we basically, I said proposed, but pretty much these are all the services that we offer at this time. And there was a couple others that are just kind of pending. As I put on here, the crisis stabilization units, we don't have them yet, but we are pending some possible approvals of being able to provide those services. So I have it on here because it should be coming soon. And ultimately, that's the plan, is to build that crisis continuum out so that we can keep individuals safe and not incarcerated, and getting access to services and therapy for up to 3 to 5 days, as opposed to less to the 23 hours that we currently can do. And I'm sorry, that popped up in my way. So we offer, we partner with a lot of the violence prevention programs as well to make sure that they have access for mental health services, not only for their clients, but also for their staff, and assess. So you can look at this grid. I really want to answer questions. I'm sorry, Elizabeth. I really want to answer questions because I feel like, we all have a laundry list of things that we offer. You definitely can go to the website. You can go past this. It's just kind of the continuum of quality care. And we offer so many things. I think it's just really helpful to kind of see what people are thinking and what would be most helpful to answer for them. Mary, I can kick it off with this first question if you want, or let you kind of guide it. You tell me.
Yeah, Elizabeth? I think we can let you answer, Dr. Tainsley. So Mary's question is, do you have a physical presence at these locations or simply respond to these different sites as part of the MCRT program?
So I think that's a great question, Mary. So I have a physical presence at the sites. And not just myself, but there's also a larger staff than just me. We also have a nurse practitioner, a physician assistant. Our psychiatrist at this point is we utilize telepsych. So we don't have a psychiatrist on site, but I am looking to make that happen. We're also expanding a few of our primary care physicians who also work in a more integrated kind of space like myself, where they're one in particular who is a med-peds trained physician who also is an addiction medicine physician like myself, is looking to expand her scope of practice. And so I'm building for her a model where she'll actually be doing some home visits at these sites. But we do have the nurses. Nurses go on site a couple times a week. They reach out to me. I see the patients at the sites for if there's any medical concerns that come up, but then also just, ongoing review of their treatment plans and those kind of things. I've had a couple times where we've had individuals who may have been on, let's say, methadone for their medication-assisted recovery, and while there have considered maybe switching over to something like buprenorphine, where it's an ideal environment for us to taper and get them restarted. I've been able to do that in certain cases, and so I usually have a presence in some way, shape, or form, but I'm not there every single day. And hopefully that helps.
If you wouldn't mind a little follow-up, I'm very impressed with the range of services. And could you just speak about the MCRT as well? Because you're a part of that. Because you did talk about the 988 crisis response.
So I do not go out on those calls. That's usually our crisis response team, our mobile crisis response team. So we have a team of individuals, mostly peer support specialists and peer recovery specialists that they're everywhere. They're on the trains. They're riding around in the mobile vans. They're at places where they know individuals are using drugs, and they're in the at the spot. They also are literally at the spot, right? They also are receiving those phone calls and being dispatched to those locations where individuals are in crisis. Our goal, a lot of times, we do bring individuals back to the crisis center on 115th, and we try to as best if possible, to de-escalate, to provide the services that they need there on site, to get them, as I mentioned before, whether it be homelessness and we're getting them shelter placed, or even getting them into recovery, into treatment, or detox. A lot of times we have to do a lot of times we're doing observation, and if somebody looks like they need hospitalization, we're getting them over to the ER, over to the hospital. We also have crisis response embedded in a couple of the hospital emergency rooms. So we have staff members at St. Bernard Emergency Room, as well as at South Shore, or I'm sorry, Jackson Park. I apologize, Jackson Park. And so those individuals are right on the spot, right there in the moment. They're able to assess patients and clients and get them, especially if they're not admitted to the hospital, they get them connected to outpatient services, and try and help them follow up and things like that. Does that help, Mary?
Yes.
Okay.
Thank you.
Yes. What's the next one? Is there a city or county website that lists? Oh, yes. And or behavioral providers to help. You may have a better answer for this, Elizabeth. I'm not sure, but I know there is. There are a couple different websites that I can think of. I think I'm going to mess on it. Opioid Response Network, I think is what it's called.
Yeah, I'm not too sure. I'm not too familiar with that one, Doctor. I know on the One Shy Fam website, there's like a public database called NowPow, which is currently being
it's changing its name to something else. Yeah.
It's currently merging right now to unite us. So I'm not sure if being able to access it this very moment is there, but you can actually go to the One Shy Fam, and I'll post it here in the chat. And at the top, there's a public resource link, and it'll take you directly there, and you can break it down by zip code, and then break it down by mental health services. So it breaks it down even further to outpatient centers, counseling, different things like that. So let me go ahead and share that. But does anyone else, anyone else on this call have any additional resources?
I put that Opioid Response Network in there. That's a good one as well, too, at least. And I'm very familiar with NowPow and Unite Us. So that's one that we use on the FQHC side. Definitely a lot of our case managers and care coordinators will use that resource. It also has some good stuff about other social determinants of recovery and social determinants of health, as they call it. There is, I don't know why I can't quite think of it, but there is, I feel like there's something also that they're working on from, specifically from the Supra standpoint, to try and help make this a little bit easier. Maybe it's the One Shy Fam, I'm not sure, but Opioid Response Network is a great one as well, too, for resources as far as education and things like that.
Yeah, definitely. And so if you click the link to go to the One Shy Fam at the top, it does ask you, or it does say find a resource if you're looking for a doctor, clinic, or other public service. So you would just click on there, and that'll take you directly to the resource. Okay, the next.
I think this question is interesting. Oh, I'm sorry. Were you going to go to Edna? And maybe Kayla can answer this.
Yeah.
Can you see it? It says, is there a data set that includes?
Yeah, that's the one we just read off. So we just read off Edna's.
Oh, okay. I thought we talked about the website. She also asked about a data set.
Yes, I did submit two.
Oh,
Thank
I'm
you.
sorry. I'm just going in order. A data set. Okay, doctor, do you have any idea on that one?
Oh, Kayla, I don't know if you have something to say on it. I can't think of a data set off the top of my head. I'm sure there's something. And
There
the
are,
only reason oh, go ahead, because I
no,
know they have
so
a
we just did that
behavioral health.
behavioral health summit at, I don't know how many of us were there on last Thursday, but I think, when we look at those data sets, it seems like they're old, right? Like we're looking at 2007, 2014. And I think that was like one of the big things that the summit, when we talk about these RFG funds coming and the data that we're trying to collect, but it's all interagency, right? And so I might collect something, but that doesn't mean that HRDI is going to have access to it. So I think the data sets there are many, but I don't know that we all have access to them collaboratively, right, or collectively. And so I think that that's something that I think we're all very aware of. And it's, I'm excited to see what the Cook County Behavioral Health, what they're going to be able to do with that data. And it's really cool to see that it's not just like Chicago, it's Cook County in general.
Yeah.
But again, a lot of the data that I think Dr. Nutter was sharing with us last week was honestly like a decade or more old. Yeah. And I don't think that that's, I just think it's just unfortunate. I think there's a lot of us like, oh my goodness, like how do we improve this? But I think we just, like they said, all of a sudden COVID hit and we didn't have the infrastructure to manage COVID. And now we've seen this uptick in all these mental health and behavioral health needs. And what was the priority? I think the priority was stabilizing the community. And now we're looking at, okay, now that we've stabilized to a degree and we have some opportunity and we've, yes, there's still some workforce development issues and things of that nature. But now they're like, okay, how do we collect the data so that when these RFG funds do come and agencies are awarded these grants and they're building these other programs and employing folks, how do we do this? What do we need, et cetera? So data sets, yes, kind of. They're old. We're working on new ones. And then the other, so receiving and not receiving, I want to say, there's a huge disparity, guys, still amongst what we're seeing. I think there was a ton, doctor, I think, I'm trying to remember, I want to say that there was just even though we've come so far, there were still like 50+% of folks that were, of color, non-white, that really, there's still a huge disparity in those individuals not receiving services. And I think we've seen an uptick in even the Asian American population with needing the mental health and behavioral services and not having access. So we could probably speak for days on, just some of those types of things. But I think that, if you're not paying attention to what the Cook County Behavioral Health is doing, please do that. Reach out, follow your local leaders, follow Dr. Nutter, and all those folks. And then it says, trying to focus on children under age 8 and expecting pregnant folks. Edna, was that a question or is that your focus at your agency?
Yeah, that's my focus in my agency, which is why I was trying to see if there was already existing data sets available.
Yeah. Yep. And I think we've seen agencies lessen their age range. And I think what we're seeing is we're struggling to find resources for kids under 5. And so, for myself, as well as like the UHS facility, which is like Streamwood, River Edge, Garfield, some of them can go as low as 3, but there's not many of us that go under 8. And I think that's probably where you're struggling, which now I understand, right? So, yeah. And I think, just, this is why things like this are really important for us to all, be on these calls and, share resources and knowledge. I was even jotting notes down when you were talking, doctor. There's a lot of great information that you shared.
Yeah, thank you. And I think what you just said actually is so important. I was at that first inaugural Cook County event too. I hope many of us were. It was very well attended and it was very well done. Especially, for the large size of it. But what you mentioned we don't have metrics that are universal that speak to each or, that can tell the story of the organizations. That was something that definitely came out a lot. Definitely that the data was old, but that they can look so different depending on the organization. And I think another thing that we don't talk enough about that is, it's legislation. It just doesn't, it hasn't had a lot of foothold just yet. But when the the Illinois Legislative Black Caucus passed the omnibus bill that had the pillars, in the health pillar, one of the one of the things that they had, approved was the building of a behavioral health statewide, like a behavioral health kind of body that could do exactly what some of these questions are asking for, right? Gather the data, kind of be a repository for it and for educating and training a greater workforce, since we're at such a shortage. But it really, hasn't been talked about so much in a larger level. And I think that's important for us to keep pushing, because it is good to have our local, but, countywide and statewide, we have a big task ahead of us. So. Expecting. Oh, I like this. Thank you for this resource. I think that's a good point. A lot of school-based things are coming out with the social emotional learning and, and those types of things. We have a school-based program as well, and we do some other work within the schools. I think